thing and turn this off after I did it, but I have to redo the talk. So we have about 30 minutes for some questions, 25 minutes or so. And so if you're near a way you can get out and go up there, that would be best for the video. If not, just signal to me and I'll come over with the mic. Okay. And you have your mic working, right? So,
I do.
John?
Thank you. It's very interesting. I'm curious about the bioethical policy implications of this.
Yeah.
You could describe what's done as a more accurate measurement of consciousness of people. Mm-hmm. And so I'm trying to envision how this maps onto current policy about when care can be removed from a person. Mm-hmm. So, how does this map onto our current standards of when parents would be allowed to end life support? Mm-hmm. Imagine taking one of these patients to the hospital ethics committee, mm-hmm. and the parents say, despite the fact that this person has covert consciousness, we still would like to end life support. Mm-hmm. Or despite the fact this is one of the few people who communicate, we'd still like to end life support.
Right.
How does this map on to the actual existing institutionalized policy in both the US and Canada about the removal of life support for people in conditions like this?
Yeah. Well, let me say that I don't think consciousness per se drives fully the issue of whether life support can be withdrawn or not. I mean, broadly, let me just speak about Canada because I'm most familiar with that setting. Although hopefully there'll be some resonances here. Proxy decision makers need to make decisions based either on the prior expressed wishes of the individual or based on their best interests. I think the real hope here is that neuroimaging assessment will give us important insight into behaviorally non-responsive patients, and that'll provide families with important information that will allow them to make decisions that are consistent with the prior expressed wishes of the patient or in their best interests. I think, honestly, I think enormously important here is the potential of assessing the quality of life of these individuals. There's so much speculation right now about what it's like to be in a state like that, and somehow we're making decisions kind of based on that speculation. I think in cases where it turns out to be possible to actually explore the subjective experience of these patients, that information is going to be enormously valuable to families and health providers. And I can imagine the decision whether to continue care going in either direction depending upon those findings. The case of children, of course, is complicated. I think. Right now, all of the research that's going on is in the context of adults. I could say a bit more, and maybe I will just a little bit later in the question period about the use of this technology in the acute setting, but perhaps let's come back to
that. Thanks for your talk. I really enjoyed it. I'm a little concerned about autonomy. Yeah. So I understand that from the point of view of a doctor, you always have the best interest of the patient in mind, and you don't want to rush into anything. But in many of these cases, these patients are intubated, which means that they, often without their consent, that is, they were intubated to begin with, right? As part of because they were comatose and they're unable to, they're unable to breathe on their own, or they're unable to, right? So literally something has been done to their bodies without their consent, right? They may actually have we may have an advance directive to the effect that, they would rather not, that these things not happen. Or maybe we just don't have very much, but we have some information from the family that they would rather not, right? Now we have the opportunity to ask them, it looks like, we have the opportunity to ask them, whether they would prefer for this. So we could ask them lots of questions, right? We could, and we could, you know, we could do it slowly. So we could say, well, suppose we improved, you know, would this improve your quality of life? Would this be helpful? Would that be helpful? And so you can go and you could do a lot of things for them, right?
Yeah.
You could maybe you know, so you could explore ways of improving their quality of life. You could explore whether they're depressed and so on and so forth. But at the end of the day, maybe after all of these questions and lots of measures have been taken, it could be that this is a patient who tells you, right, please stop. You're, you know, I don't want to go on like this. My concern is, who are you, right? Or who are, you know, who is the hospital to be making that kind of decision? Who is the family, frankly, to be making that kind of decision for the patient? Isn't it up to the patient? We have now access to what the patient, I mean, certainly in locked-in syndrome and so on, we have access to what the patient wants. Why isn't that what's the really should actually be determining the answer to that question?
Well, I mean, I don't think we're going to disagree about this. I mean, I think the autonomous patient is exactly the person best placed to make that determination. And should someone, after a catastrophic injury like this, autonomously decide that they do not want continuing life-sustaining interventions, I think it's morally obligatory to stop them. Okay, I mean, I think that much is really clear. The difficult part is figuring out whether you're dealing with someone who is in fact autonomous, right? And that's the challenge. And it's I mean, I think one of the main challenges that underlines the whole idea of having surrogate decision makers is, in a sense, the importance socially of protecting individuals who lack autonomy from the harmful consequences of bad decisions, right? That, in the clinical setting, that means that physicians and neuropsychologists spend a lot of time, when there are questions about autonomy, doing a very careful clinical assessment of someone's decision-making capacity. The real challenge here is that we can't straightforwardly apply any of those sort of structured interview techniques to patients like this. So, I mean, I guess I too believe and am motivated by the fact that if someone is respect for autonomy, in fact, requires not only that we respect individuals who we know straightforwardly to be autonomous, but it actually confers upon us a moral obligation when it's unclear to search for it. And to me, that's how I understand this work, is a stepwise attempt to find autonomy when it's there, and when it's there, to respect it. But it's, I mean, as I hope I've begun to show, at least, it's really difficult. We hope to start in the most tractable place, namely just kind of low-stakes, day-to-day decisions, and then move on from there. That's our approach. I mean, I hope it's one that bears fruit, and I hope it's one that in a, you know, in just what we're talking about, in a way that gives voice to these patients.
I don't need a mic. Okay, so in these cases, what you've shown is there are lots of degrees and different kinds of consciousness, raising the whole issue of when a life is worth living. But in the end, somebody's got to make the decision, right? Yeah. So I think what we need here is a theory of rights in these contexts. The right of the individual, if he or she can understand, you know, the defects that he or she is liable to, the right of the parents or surrogates, and the right of medical decision makers. Because otherwise, you have no standard for how these decisions should be made. So I think in the background of your argument, which is a great argument concerning all the different kinds of deficiencies and abilities of consciousness,
Yeah.
in the end, somebody's got to make a decision.
Yeah.
Not just live or die, but how much resources
Right.
should be expended
Right.
on people with different sets of abilities or disabilities.
Yeah.
And for that, you need a set of who has the rights and authority to make the final decisions.
Right.
That's a classic political theory issue in medical ethics. But if you don't have an answer to that, all you've got is ambiguity.
Right. Right.
Right? So it's
So-
a follow-up of Sam's question, but
It
I
is.
think it's a question about how do we understand who ultimately has the authority to make these decisions, and what are their rights, and what happens when the rights of the patient, the family, and the doctors come into conflict.
So that's
yeah.
that's really a great point. You know, I think we do know something about that. So I mean, it's in any state and among the provinces in Canada, there are sort of laws that set out both the patient's right to self-determination, and then the role and responsibilities of surrogate decision makers. Similarly, in many jurisdictions, and Ontario is the one I'm most familiar with, there's a mechanism for dealing with conflicts between healthcare providers and surrogate decision makers. In Ontario, we call it the Consent and Capacity Board. And when there are disagreements, particularly around either whether someone is capable or not of making a decision, or importantly, and I think this goes directly to your point, when there are conflicts about, you know, should we keep going, or is enough enough, right? A crucial kind of conflict like that, that is brought to an administrative mechanism called the Consent and Capacity Board in Ontario. Importantly, it's staffed not only by physicians and psychiatrists and allied health workers, but also representatives of the public, right? Because these aren't merely medical issues, these aren't merely legal issues, these are social issues. How we treat the most vulnerable among us says something about all of us, right? And so these mechanisms broadly exist. There's a lot of variation, and I think I take part of your point to be that in areas that don't have fully developed mechanisms like this, we ought to have better mechanisms in place. The issue of resource allocation and sort of conflicts between the treatment of the individual and scarce resources at the level of the state is really tough. And it's particularly tough in traumatic brain injury, I think, because overwhelmingly these are young people. And it's some of whom will go on and do well, some of whom will go on and live with disabilities but lead meaningful lives, people like Scott. And I think as a society, I don't think there's a consensus about how much money is enough to spend on this. But as a society, we're going to have to grapple with this, right? And I take that as one of the unanswered questions here, is how much resources do we invest in particular cases? So thank you for that.
Yeah, thanks. This was really, really interesting. I'm curious, so obviously you have more research to do, but if it continues in this kind of promising direction, do you think there's a point at which testing like this becomes obligatory for patients in vegetative states like this? It seems like there might be ethical issues in both directions. People, you might want to know before you pull the plug whether somebody has awareness, but that might also lead to problems if you test everybody. I don't know. So I guess I'm just curious what you see.
So that's yeah. I mean, I guess I see it in the following way, that there may be a dispute within a particular family about the best sort of course of action, right? And I can imagine a case in which part of the family wants continued treatment, and perhaps the person who's acting as surrogate decision maker wants to withdraw treatment. And under those circumstances, and this has come before the courts, where those members of the family who are in favor of continuing life support and continuing life-sustaining interventions might say, look, we should do some neuroimaging to get a better sense of what's going on here. The surrogate decision maker is meant to make her decision in very specific ways, right? Either in terms of the prior expressed wishes of the individual or that individual's best interests. It's very difficult for me to see, unless there was sort of a clear expression up front that someone wouldn't want treatment of a particular sort. If a surrogate decision maker is trying to figure out what's in the interests of an individual, it seems to me, I'm having difficulty imagining why a surrogate might actually decline the sort of information that this non-invasive neuroimaging could provide. Knowing that someone is covertly conscious, it seems to me, could be highly relevant to their interests. Knowing that they're capable of experiencing not only suffering but pleasure. And with some work that I haven't described here today, there are some other neuroimaging studies that are actually getting at higher level cognitive abilities, including the ability to follow sort of complex narratives and have appropriate affective responses. And I think that gives us at least indirect evidence of someone having the potential for higher level interests. So yeah, and I think in a case like that, it'd be hard to understand how it is that what good reasons a surrogate could have for declining that sort of investigation. Yeah.
Hi, I'm interested in the possibly 83% that have not regained any kind of covert consciousness. I have kind of a nexus of questions.
Mm-hmm.
Have you found anyone who didn't demonstrate covert consciousness who later then did? Or was it sort of like a one-off test and you either had it or you didn't? Is it possible that the brain continues to heal over time and an fMRI might at one point not reveal covert consciousness but later reveal it?
Yeah, I mean, we know clinically that happens. I mean, people will emerge from vegetative states, sometimes of months or even years duration. It becomes rarer as time goes along, but they do show, I mean, those cases in which there is recovery, I mean, that's evidence of neural recovery. I think your question is a great one because really you're asking, in part, are we examining patients over time? The answer to that is yes. Patients, where feasible, are brought back to the Owen lab for repeat tests and as they develop sort of new and interesting ways of getting at covert cognitive activity. So that certainly is going on.
Yeah, it's sort of all fueled by my concern about the ethics of those who don't have covert consciousness. So in your second point, when you're talking to the families and doing these qualitative interviews, do those also include families whose loved ones aren't covertly conscious? Or are you just... Okay.
Absolutely. Yeah, I mean, we're very interested in how broadly families respond to any of the results that are provided. So, in fact, those are clearly positive results, indeterminate results, and negative results. One of the real difficulties here, and I'm really glad you asked this, is that a clear positive result where someone can clearly and reproducibly follow the mental imagery sort of task paradigm provides fairly clear evidence, I think, that someone is covertly, consciously aware. But the fact that someone is unable to do it doesn't tell us that they're not covertly, consciously aware, because they could suffer from other defects, cognitive defects that simply, even in the face of consciousness, don't allow them to complete the task. I mean, one thing is, is the patient can just be asleep, right? They could be distracted. They could have difficulties with attention. But they could also have selective sort of linguistic defects, right? They may not be able to process speech, right? And so they may be conscious, and you're saying to them, now imagine playing tennis, but they can't understand what you're saying. So how do we deal with those negative results? That's something that I know Owen and his team, they deal with, I think in a very sensitive way with families. But it's the negative result for me is actually the most problematic in the sense that we don't definitively know what it means. It means perhaps the patient isn't consciously aware, or perhaps there was just a failure in the test conditions, right? And that's difficult. One of the worries is that that fact is actually going to be difficult for families to deal with, and that's part of the reason why we're talking to the families. Of course, we're not just interested in covert awareness, and so families are presented with a broad array of results of a whole series of tests. So often Owen's team is looking at sort of whether they're able to process sound, whether they're able to process speech, is there evidence of semantic processing. So there's often, an array of cognitive functions that they're given a report on. But negative results are complicated in this setting. Yeah.
Hello. Thank you for just a terrific presentation. I'm a physician. I'm on a hospital ethics committee. Mm-hmm. For a year, I was the medical director and sole clinician for a ward of people on respirators, yeah, some of whom were brain damaged. Yeah. But my first observation is a philosophical one. You're really talking about Plato's shadow in the cave and how medicine perceives gestalts that try to discern reality from illusion. Mm. And your discussion is really one of the whole paradigm of medicine. Mm. And during our lifetime, if we think of people with kidney failure, yeah, who went through ethics committees and then got kidney transplants, or people with heart failure who now can have LVADs or heart transplants. Yeah. Now we have patients with brain injury. One of the ethical considerations that you hadn't talked about is that these patients are all chronically ill, and their patients and their family have dealt with this circumstance over a period of time. Yeah. And I think that incubation period very much discriminates this ethical situation from what goes on in the emergency room.
That's absolutely right. So for instance, in our family interview study, it was purposeful that we required patients to be at least 1 year post-injury, is because we were worried about the potential harms of interviewing people and asking them to tell difficult stories. I can say that this technology now is being applied in the acute setting. So Adrian's team is currently collecting a cohort of 125 patients within hours or days of traumatic, within hours or days of brain injury. So these are patients who are intubated, ventilated in the ICU, and who are brought down to the MRI scanner to look for covert cognitive function. To me, this is enormously important work. And it's motivated by the idea that if there's evidence, nobody expects any of these acutely comatose patients to be covertly aware, but never say never, right? But if there's evidence of kind of higher level intact cognitive processing, it may be that turns out to be a predictor of good outcome. And given the extent of withdrawal of life support that happens in the ICU setting with exactly these patients, I think that could be of enormous importance to patients and families. Not in the sense that it says, we must treat this patient no matter what, but in the sense that it might give families a reason to say, let's give this a couple of weeks and see what sort of improvement we see. So that's a new area. I would love to talk to families in that setting. You know, we need to assure ourselves first that we can do so in a safe way and in a way that that doesn't lead to untoward consequences.
I'd like to jump to a comment you made talking about the brain-computer interface.
Yeah.
So if you can attach your MRI results to a computer, the next step is therapy, which is operant conditioning. Based on the yes-no responses of the patient, you could expand his capabilities.
Well, yeah, I mean, there's a great deal of interest in the chronic patient population. Are there things we can do, particularly in patients that have a good deal of preserved cognitive function, that will promote, you know, sort of more brain healing and help get us a better outcome? I know there are a number of ideas that people are working with in this area, and you know, hopefully some of them will turn out to be effective.
Okay.